All right, this is the crash course in teaching diagnostic reasoning. This is part 7, when diagnosis and treatment intersect, what some folks have called management reasoning. Now, I personally argue that management reasoning is really not a separate competency from diagnostic reasoning, but some folks argue otherwise, and we're not going to get into that during this brief talk. But I'm going to talk about concepts that fit into both of those, right? So whether or not you're in the management reasoning camp or not, we're going to talk through how diagnosis and treatment intersect and how we think about that clinically all the time. So let's revisit a case and let's use Bayes' theorem here. So let's go to a case that I think I talked about in a previous talk of an older woman who is very, very likely to have symptomatic coronary artery disease. And this is an older woman who's smoked, has hypertension, hyperlipidemia, whatever. And let's say our pretest probability is 90%. Before ordering a stress test that she has symptomatic coronary artery disease. Well, even with a nuclear stress test, that's a really good test, but a negative stress test has a negative likelihood ratio of 0.16 for identifying obstructive coronary artery disease. So I've drawn a Fagan's nomogram over here. Even if I get a negative stress test at that negative likelihood ratio, even with a negative stress test, her probability of having symptomatic coronary artery disease is still 50% with a negative test. So my pretest probability is so high that even a pretty good diagnostic test still does not really bring me into a range that I'm comfortable saying this is not symptomatic coronary artery disease. So one might make the argument that I would just simply treat it here, and whether or not I want to refer her for an invasive, coronary catheterization to determine the anatomy of that obstructive coronary disease, or if I just want to put her in medical management with, beta block or nitrate, etc., and see how she does, see if I can manage it medically before committing her to any sort of invasive approach. I can use the concept of test and treatment thresholds to sort of reason through that. So we can view the stress test, or really any decision making that we do in clinical medicine, around this concept of thresholds. And this concept has been around for over 40 years. It was introduced in the New England Journal of Medicine in, I think, the late 60s or early 70s in a series of articles. And any diagnosis in medicine can be conceived of as existing on a spectrum of probability from 0 to 100%. And I personally would argue that nothing is ever certain. We never have, clearly are 0% or at 100%. We can feel very, very close, right? We can get biopsies that have been read by 2 pathologists with a second opinion and are discussed in a tumor board or something and say, okay, we are very, very confident this patient has this type of cancer. But nothing's ever 100%, right? We'd say 99.99% chance because there might still be some sampling error. We might have misstained, or there's other things that could go into that, right? Anyways, that's a little bit of an aside. But for most of the diagnoses that we're encountering on a regular basis, we are existing in a space of uncertainty. That we have a certain probability that's not anywhere near 100%, but is nowhere near 0%. And we need to decide, are we going to test for that disease? Are we going to empirically treat for that disease? Or are we just going to sort of watch? Now, of course, if the probability is very low, the stakes are not very high, something benign, we might say, don't test. The testing threshold has not been met. On the other hand, we have a case here, like I'm discussing, a woman with a very high probability of coronary artery disease. I am just going to empirically treat. I'm above the treatment threshold. And as I've seen before, even if I do diagnostic testing, I'm still not going to get below that treatment threshold, right? Like I might argue that anybody with a decent probability of coronary artery disease and who does not have a competing diagnosis, you should just empirically treat, right? Little beta blocker, a little bit of a nitrate, what are the harms of that? Pretty minimal, some side effects of medicines, right? But if my patient is having disabling angina, I'm above the treatment threshold. I'm just going to start treating for it. And as we work through this example of coronary artery disease, we can already start to see that the testing threshold and the treatment threshold are actually influenced by a lot of other factors. The severity of the patient's symptoms, the probability of the disease, the risks of missing the disease, whether or not the patient wants to go through with invasive testing, whether or not the patient's amenable to taking new medications. Now, normative reasoning, or pure Bayesian reasoning, very mathematically sound reasoning, would say only test if we're between these 2 thresholds, right? Because only then are diagnostic tests going to substantially influence our probability to the point of making us feel like we don't need to test any further, or we just are going to start treating. In other words, it's the old adage, will your test change management? And that really is like when you're in the space, between testing and treatment thresholds. If the test is not going to change management, you either have a disease that you really weren't worried about, so you shouldn't test, or you have a disease that you really are pretty confident the patient already has, and you're just going to empirically treat. Or you have a patient who's got a non-specific syndrome and you're just going to sort of watch it over time because you're not really crossing the testing threshold for something more dangerous or the treatment threshold for something more dangerous. So this slide is courtesy of my colleague Philan Vijayasekara, who's out at Yale, and he has really solidified this for me when we think about management reasoning, and thinking about the test and treatment thresholds. These are very flexible and they're very disease specific and they're very patient specific and clinician specific, right? So when to test or treat varies case by case, right? If I'm thinking about aortic dissection, I might test at a very low testing threshold because I don't want to miss that, right? Even if I feel like the patient's got a 5% chance of having an aortic dissection, if I'm an ER doc, I'm probably going to get the CTA to rule it out or move that threshold very, my confidence much higher and my probability of disease much lower. So my testing threshold in aortic dissection might be 5%. Or something that I encounter as an ICU doctor fairly frequently is wondering, does this patient have bacterial meningitis? Even if the probability is quite low, the risk of getting an LP and the complications from that are really pretty minimal. So if a patient's got normal coagulation parameters, I'm probably going to test for that because it might influence my spectrum of antibiotics, for example, or how long I treat for sepsis. So that to me is another example of kind of a do not miss diagnosis where our testing threshold might be very low. On the other hand, I can use the example of my clinical practice of sepsis, right? Like if somebody comes to my ICU with hypotension and wide pulse pressure and fevers, my probability of sepsis has already been met for treating. If I miss it in those first 24 to 48 hours and don't treat, the risks are just too high, right? Mortality increases with delays in recognition and treatment of sepsis. So my treatment threshold for sepsis, at least early in meeting the patient, is very low. It might only be 10 to 20% that I'm just going to empirically treat. Now, of course, I'm going to be doing diagnostic testing in the background, but my treatment threshold's been met. And of course, as time goes on, I'll have a little bit better clarity of whether or not the diagnosis of sepsis was even reasonable to have considered, but my treatment threshold's been crossed. So we can see that all of these thresholds are set by lots of different parameters. The patient themselves, their personal preferences. So if I'm in an outpatient setting, their tolerance to risk, their health literacy, the family input, all of these things might influence whether or not I test or treat for things. Similarly, their physiologic reserve or their age or comorbidities matter. So again, the example of sepsis, if they're older and they're immunosuppressed, my treatment threshold is much lower than a 20-some-year-old who's coming in with a fever who has normal, stable vital signs. I may not even give them empiric antibiotics because my treatment threshold is different for that young, stable patient with a lot of physiologic reserve versus the old patient who has no physiologic reserve. As I've already kind of talked about, the disease itself and the acuity of it and its potential for harm are all going to influence whether or not I test for something. So we have a much lower testing threshold for things like aortic dissection or bacterial meningitis than we might have for, I don't know, give me some benign musculoskeletal disorder that really doesn't have a surgical management. In that situation, I'm not going to get an MRI for everybody that bruises their elbow because what am I going to do with that information, right? And the harm potential of missing something major, like, I don't know, what are the serious problems of the elbow that are going to lead to long-term morbidity and mortality? There probably are not very many. Then, of course, other things are going to influence this as well, the provider and the team. So my personal preferences as a clinician, my own tolerance to risk. In terms of my own decision-making, my knowledge about the diseases I see or my experience with them might influence this, right? So I see a lot of relative adrenal insufficiency in the ICU. I'm very confident giving empiric treatment for it. My treatment threshold is very low. However, somebody that does not see this all the time might check cortisol or might want to seek endocrinology's expert input onto this. So that will also set test and treatment thresholds. Context matters too, right? My mood, my distractions, my workload. If I'm very busy and I have a large cadre of patients to manage, I might lower my testing threshold for things because it's going to, I'm not sure where to set the testing threshold. I don't have the time to think through it. So I'm just going to order additional tests to increase my diagnostic certainty because I don't want to sit here and reason through this all day long. And then, of course, the system also influences this, right? The workload, the distractions, the safety culture in my environment, the costs and resources. Do I have, time to manage this patient expectantly? Is there the bed availability to manage this patient expectantly? Is a test cheap and very high performance? So, something like a pro-BNP and heart failure, if I'm in an observation unit in an emergency room and I'm not sure if the patient has heart failure, well, pro-BNP is really cheap and the test performance characteristics are really good. Even if I'm not really suspicious of it, I might just get it because that's going to save me a downstream echo, for example, that I might just get the pro-BNP and really substantially increase my diagnostic confidence that the patient has heart failure. And of course, medical legal risk, we would be remiss not to mention it. This might go through more of our minds as teachers and clinicians than it does for our learners, but certainly as part of setting the test and treatment thresholds as well. So I think threshold concepts help us conceptualize a lot of things. First of all, I think for me, it solidifies how diagnoses and treatments intersect, right? These are the decisions we're always making on a daily basis. Is my patient, am I worried enough this patient has it? I'm just going to treat for it. Am I worried enough that I actually need to test for this? And I think this intersects with the overlapping confluence of how uncertainty influences what we do. So if we're not certain, our test and treatment thresholds might be, very far from where we're operating in this middle gray space, and that uncertainty influences, our desire to obtain more testing and increasing our diagnostic confidence. And again, I think this is just how flesh and blood decision making works, right? So we could wax poetic, philosophic, whatever. We can pontificate about diagnostic reasoning all day, but at the end of the day, we're taking care of patients, and we need to decide, are we going to get additional diagnostic testing to increase our diagnostic certainty? Are we going to empirically treat for this or that? So that's just, how we operate in a clinical environment. And we, at the end of the day, these are the decisions we need to make. So the test treatment threshold concept, I think it sort of takes the diagnostic reasoning concepts and makes them very concrete for learners, and sort of thinking about, okay, we've thought about this, probability is still intermediate, we're just going to have to make a decision here. We're going to get more tests, we're going to treat, what are we going to do? And that's sort of like, anybody that's rounded with me, I get impatient at some point. Like, we just got to do something here, right? We have to decide, are we going to watch this, or have we crossed the threshold that we're going to treat, or have we crossed the threshold that we're going to test? And then I think ultimately, I'm not a guru in patient-centeredness, but this is how patient-centered care works, right? This is where we involve the patients in, are we going to manage this expectantly or not? And the diagnostic probabilities and the set points of the test and treatment thresholds are certainly going to influence this. Like, the patient may not be interested in taking another medication, and we'd say, okay, well, the treatment threshold then maybe is a little bit higher for wanting to empirically start you on a nitrate and beta blocker for what may be symptomatic coronary disease, because you're already on 10 other medicines, including 2 other antihypertensives that may not play well with these 2 medicines. I agree. Let's just hold pat and see if your symptoms evolve in a way that further influences our treatment threshold. So we can go through a lot of examples. I won't belabor these, right? But if we see knee pain in an average Joe, 50-year-old guy falls and injures his knee while working, in his yard, first we might ask ourselves, is this a knee fracture, something that's dangerous? And, our probability of knee fracture might be intermediate. And we might say, okay, we need to get further testing to sort of influence this. But then we might use, for example, the auto knee rules, and now we're below the testing threshold for further imaging. And we say, okay, we can confidently say don't test. On the other hand, we might not be thinking about knee fracture. We might just say, okay, we don't think it's a knee fracture. That's in the don't test space. At the same time, you're not feeling particularly well, so whether or not this is a contusion or prepatellar bursitis or whatever this is, you probably have reached the threshold for empirically treating that. The risk of giving you, sir, empiric NSAIDs is pretty low. We're above the treatment threshold for other causes of knee pain. Let's just go ahead and treat. If you want to use the example of iron deficiency anemia in an elderly woman, what is the probability of colon cancer? Well, I don't know what that is. I actually don't know. Is it 20%? Something like that, 25. So, an older woman, iron deficiency anemia, we have to be worried about colon cancer. And we might set the testing threshold very low here for getting a colonoscopy, even if she had one maybe 3 years ago, because the risks of missing something like that are bad, right? Colon cancer is a damning diagnosis that we don't want to miss. So I might shift my testing threshold for a repeat colonoscopy much lower because I, haven't found an alternative good explanation for iron deficiency anemia. And even though a colonoscopy is not without some risk from the procedure itself, the testing threshold has shifted because of just the long-term consequences of missing something like cancer. So I think other concepts overlap nicely with thresholds. For example, the test of treatment. So sometimes we don't know the diagnosis and we just empirically treat and we assess the response to move closer to 100%. So sometimes, I'm really not sure if somebody's got heart failure or not. So I might just treat them with diuretics. And if they substantially improve in the next 8 hours after I thought they had heart failure, I might feel much more confident that that's the diagnosis I'm dealing with. So it doesn't fit perfectly within the thresholds themselves, but I might be in this treatment realm, and then I treat and I watch how the patient responds. I move it closer to 100%. On the other hand, if the patient doesn't respond as expected, and this sort of starts to align with illness scripts, if the response to treatment is not there, then I might say, okay, I'm actually below the treatment threshold for this disease now, and I'm actually have to think about other diseases and sort of figure out where I am on the test treatment thresholds for those diseases. And again, like test of time, I think is a beautiful way to conceptualize thresholds as well, or sort of think about how they overlap with thresholds. And the test of time is simply allowing time to tell when I've crossed a testing or treatment threshold. So, for example, I might see somebody and I'm a little bit worried, and we've thought about the diagnosis. You've got some back pain. You got some yellow flags, but no red flags. Why don't we just give it a couple weeks before we get further imaging? Because right now my probability is low enough that I'm below the testing threshold and I'm not even going to test. But if it's worse than 2 weeks, now I've gone beyond the testing threshold and I'm now back in this middle space where additional testing is required. So this is a nice way to sort of think about expected management. Expected management should be done when you're either on the no test end of the spectrum, probability is very low, and you just want to watch it over time before you get additional testing, or you're on the high end of the spectrum here, right? Like the probability is very high. Let's empirically treat for the condition, and if let's do some PT for that knee pain, and if your knee doesn't get better, then we're going to get imaging because now you haven't responded to treatment, and we have to think about a more serious diagnosis. Some other concepts I think overlap with this concept of thresholds, and I think that in particular uncertainty does. And I haven't put the word uncertainty on this slide, I'm sorry, but these are all different types of uncertainty, and I think this sort of aligns not perfectly with test treatment thresholds, but it's the only other place I can sort of fit uncertainty into this crash course in diagnostic reasoning. So there are three big types of uncertainty. One is just sort of clinician or personal uncertainty, and that's sort of the subjective sense of unease or ignorance. Like, I'm not sure what's going on here. It doesn't feel right that I don't know what's going on. Now, is that alleviated by more testing? Not necessarily. So, if we're uncertain for some reason, that may be because we're in between the testing and treatment thresholds, or it may just be because we don't know enough about this disease, or we just don't know enough about this patient or whatever. So testing may actually give us a false sense of security, particularly if our probabilities are not shifted by the tests we order. So if I'm worried about something and I actually order the wrong test for it, and the test is negative, I might feel better myself. My personal uncertainty might feel better, but actually have not significantly shifted diagnostic probabilities. So that is not a good use of testing, that type of uncertainty. Then there are two other major types of uncertainty, and this starts to get in philosophy a little bit, but there's what's called aleatoric uncertainty, and that just exists from the randomness in the world and the variability in test performance, for example. So there might be a patient that I'm like really worried about something, and I'm uncertain, and I get a test and it comes back negative, and I'm like, I feel a little bit better, but there may just be the randomness in the world that patient ended up being the one patient in 100 who tests negative when they actually should have tested positive because the test failed for that moment in time. So if I'm still feeling uncertain about that patient or feeling anxious about this patient, like, wow, we got a CTA. I thought you had aortic dissection. We got a CTA. It was negative. Maybe we should get a TEE and look at the aortic arch a little bit better because I'm just not feeling good about this. And sometimes the CTA is not perfect. So that type of uncertainty is actually alleviated a little bit by additional testing because an additional test that comes back negative now is going to move my certainty to nearly 0% probability that you have an aortic dissection. So that to me would be like sort of an example of aleatoric uncertainty playing out. That I get a test, it moves my probability substantially, but I'm still feeling unwell about this situation for some reason. There's just something about this patient case that makes me think that the patient may still have an aortic intimal tear, and I'm going to want to get some other additional testing to figure that out. And then the last type of uncertainty is what's called epistemic uncertainty, which is sort of that we just lack scientific knowledge about a certain disease or condition. So for example, I'm going to use a relevant, at least timely, when I'm recording this, COVID-19, when this first started coming around, we just didn't know that the test performance characteristics, and we really still don't, of nasal PCR for picking up COVID-19. So I wasn't sure what to do that. There's epistemic uncertainty there, right? Like, what is the test performance characteristics of the nasal swab for this disease? So I actually wasn't sure, is repeated testing going to help with that or not? And the answer there is, probably not. So if I'm not sure of the diagnostic test performance characteristics, it may not completely move my probability, and it may not actually resolve my own subjective sense of unease, my own clinician uncertainty or personal uncertainty. So that's sort of getting very philosophical there. But then we start to run into some limits of our scientific knowledge, and some uncertainty is simply not resolvable through these concepts. Anyways, that's all I have to say about test treatment thresholds and management reasoning. I think test treatment thresholds are the best way to conceptualize management reasoning and to start to pull into some of these concepts of expected management, test of time, a test of treatment, and uncertainty and ambiguity in seeing patients.